Yeah, we're live on Facebook as well
Brilliant.
now.
Thank you. Thanks, Tony. Good morning, everybody, and welcome to this Facebook Live session where we're going to be focusing today on nursing and midwifery workforce, particularly looking at recruitment and retention and the work that's going on around both bringing new nurses and midwives into the organisation and keeping our nurses and midwives here, and the wellbeing work that we're doing. My name's Lorraine and I'm the Chief Nurse, and I'm joined here today by a number of colleagues, and we'll just go round so that they can introduce themselves. So Lisa.
Hi, my name's Lisa Enoch. I'm the Education Lead for Critical Care.
Thank you, Lisa. Amanda?
Hi, I'm Amanda Small. I'm the Interim Deputy Chief Nurse.
Thanks, Amanda. And Ansley.
Hello, my name's Ansley Donald and I'm the Deputy Director of Workforce.
Thank you, Ansley, and obviously joined by Tony from our comms team as well. The purpose really of today is to answer some of the questions that we're hearing when we're going around talking to teams. Invariably, when we're going into clinical areas, talking to all of you, we're hearing some of the same questions being asked around, why are we constantly short-staffed? What are we doing to bring more nurses into the organisation? We're losing nurses. Where are they going? What's the real picture? We tried a number of different ways to communicate this information out, including huddles with the heads of nursing and briefing sessions with the matrons and sisters, and written communications either through email or through bulletins that are printed off and shared with teams. But we constantly still have these themes that are coming through. So we thought that it would be helpful for us to have a panel conversation, question and answer session around the key themes that are coming up, so that we can try and share with you where we are at the moment in the organisation, trying to bring in some additional staff, recognising that it is really still it really is tough out in the organisation, and that we are really in some areas really struggling with staffing and having to constantly move staff across to keep patients safe. So if we start with one of those actual themes, Ansley, we constantly hear when we're going out that we are short-staffed, and we don't know what our vacancy rate is. We don't know how many nurses we're missing across the organisation. Would you mind just taking us through where we are with vacancies, both in our registered nursing workforce and our midwifery workforce and our support workers?
Yes, of course. So I will be upfront and say there are huge caveats around the data that I'm going to say. So I'll give you the vacancy rates as a percentage, but then I will explain to you why they are perhaps not accurate and why it doesn't perhaps feel mirrored on the wards and in clinical areas. So according to our establishment, we're currently sitting with a 8.6% nursing and midwifery vacancy rate, but that's 8.8% for nursing if you take out midwives, and midwives are sitting with a 17%. So you can see that when we amalgamate these numbers, often we mask where we've got very high vacancies. Another example would be paediatric nurses, where we're sitting at around a 26.1% vacancy rate at the moment, so that's incredibly high. But overall, we're at 8.8%. There's a further caveat to that, and the reason that is that we know our establishments aren't recorded correctly at the moment. So the rosters are correct, we are working to our ratios, but the establishments as recorded aren't. So we know it doesn't feel like 8.8% vacancies across the organisation. It feels much higher because at the moment it is higher. Just a little bit about healthcare support worker vacancies as well. We're currently sitting at around 2.1%. Again, it's going to feel higher than that because the actual day-to-day running of the organisation, we need more than is currently in the established posts. And we're working on that, and Lorraine, I know you've been doing a lot of work on the establishments.
Yeah, and it's probably worth just picking up on the establishments, isn't it, so that people can understand, because again, that's a common question that's asked around, well, how do we decide the number of nurses that are required to work in each area? There is a process that we follow for the inpatient wards, which relies on the SNCT data collection that we do 3 times a year. So most people working on wards will know that we collect the acuity of patients at 3 periods throughout the year, and then that gives us a number of staff that are required to care for those patients with that level of acuity and that specialty. And then following that, we will end up with a number, and we work very closely with the divisional teams, the heads of nurse and the matrons and the sisters charge nurses around, this is the number that the SNCT gives us. What's the professional judgment on top of that number? And that might be, so what's a mix between registered nurses and healthcare support workers, and is the number that SNCT gives us correct? Now, in some cases it isn't, because if you have small wards, SNCT doesn't necessarily take that in as a factor. It does factor in side rooms, but it doesn't factor in specials. So once we've gone through that whole professional review and challenge, all of the establishments are then challenged further through the nursing and midwifery and allied health professional advisory group, prior to them being taken up to the board of directors for approval and sign off. Because of where we have been over the last year and a half, 2 years with COVID, the SNCT process has been more difficult, because specialties have changed, wards have changed, and the patients that are being cared for in areas have changed, and therefore it's taken us longer to complete the establishment reviews. But for the second half of the year, we now have the approved, signed off establishments as agreed using SNCT, and as Ansley said, these will now be aligned to the financial ledger, which will then allow us to really report truly accurate vacancy rates. Also, just to be clear, as Ansley said, we haven't actually changed the rosters. So the rosters have been running as they should have been, with safe numbers or safely set numbers as aligned to the SNCT, but we haven't actually been reporting accurate vacancies. So I hope that explains how we set establishments across most of the ward areas. It's different in areas like critical care, isn't it, Lisa? We are required to achieve certain standards. So the GPIC standards apply within critical care, and we set our establishments based on those. Lisa, did you want to add anything?
Yeah, and like the wards, we've had a difficult time as well, but we have got new starters coming in, and we are working hard to meet the GPIC standards. The new starters obviously need lots of training, and I think you probably heard in the press it can take up to a year to train a critical care nurse. So although we've got staff coming in, it's not the quick fix that we all hope for, but we're work in progress, so that's good.
Yeah. And there's some unique challenges, isn't there, Lisa, in different areas. So critical care is a classic example of where it does take staff longer to get fully trained. Theatre's another area, and maternity, which we'll move on to shortly, it is another area where it can take longer. And there's all different specialist skills that take staff a while to get into and up to the level that they need to be.
Yeah, so we work on a step competency, and so step 1 is the first year of the journey of a critical care nurse, and that can take 9 months to a year to complete, to make you ventilator competent. So and then there's filtration and there's inotropes. So yes, it's a year program really to create a critical care nurse. Yeah.
And in terms of setting establishments, just to say, for midwifery, we use a different tool, which is the Birth Rate Plus tool, and that's a formal review that happens with an external reviewers come in to look at our numbers based on our birth numbers, and that again will give us our standard that we should be working to, and we are established we're established to recruit to the number of midwives that we need to be compliant with Birth Rate Plus. The issue, as Ansley said, is that actually we have got high vacancy rates within midwifery. So that's how we set establishments, and that's where we currently are in relation to vacancies. I guess the other question is, so what are we doing about it? What does the pipeline look like? Who's coming in and when will they be here? Who wants to take that? Ansley, Amanda?
I'm happy to. Yes, I'll start and then Amanda will follow, I'm sure, with what we're doing to support people as they arrive. So we have recruited an incredible amount. The organisation has, you have, the people who are on the wards supporting these people arrive. So since January to October, we've welcomed 412 new nurses to the organisation, and we've welcomed 34 midwives and 340 healthcare support workers. So those people are new to our organisation. So it's fantastic that we've seen those numbers come in and choose CUH as the place where they want to either start their career as newly qualified or relocate to. So some really good numbers there. And I know Amanda's team has been working with wards, clinical areas to really support them in terms of having a good welcome, a good landing and preceptorship and development.
Great,
Yeah.
thank you. Sorry, Amanda, over to you.
Oh, that's okay. So yeah, lots of support that we're trying to put in practice. I guess we recognise that it's great that we have all of these new starters coming in, but actually when staffing is already challenged, it does add another layer of complexity and pressure into an area to be able to support those individuals to have a good landing in the organisation, and for them to have time and capacity to develop the skills that they need to be able to support you in your ward areas. So what we have done is we've got 6 clinical educators that are starting. We've had 2 that have already started and another 4 that are starting over the next 2 months, that are going to be working specifically out in the clinical areas, in the divisions, alongside the practice development nurses, to work with new starters to help them build their skills and also support them to develop further in their career. So if anybody has got any particular area that they feel that they need some support with, if you could contact the clinical education team, and we'll ensure that we've got a plan in place to support you.
And Amanda, it's true to say, isn't it, that there's been lots of bids put in through to the Health Education England over the past year or year and a half for additional funding to help support education in practice, and that's where the 6 clinical educators have come from. Are there any other posts that are worth mentioning?
So we've had a number of bids, as you've said. So we've got clinical placement expansion programme as well, which is looking right back at the beginning of the pipeline, really, and how we support students in practice to have a good quality learning environment. So we have 2 posts there that one is focusing on AHP placements, one is focusing on nursing and midwifery placements, to look at how we expand placements, but also what is the support network that we need to put in place to ensure that staff are supported to give people a good learning environment when they're here. We also have appointed a healthcare support worker retention lead as part of the bids, Sian Parker, and I know she's been out working in the divisions with you all, looking at how we can better support healthcare support workers to stay working with us. So that may be how we ensure we're recruiting the right individuals, what support networks we've got in place, what training we give them, and looking at bespoke support and training in certain areas. So she's particularly been focusing in Division C with our DME wards to give them skills and support so that they can care for that demographic of patient. Additionally, we've put in a post with HEE funding to support functional skills, because what we recognise is that a number of our healthcare support workers do actually want to go onto the apprenticeship pathway, but may not have the required level of maths and English to be able to start that pathway.
Thanks, Amanda. So I think there's some good pipeline. We've got some good numbers of people that have started us, and good pipeline of people coming in, and there's 3 main routes, isn't there, Ansley? So we have the newly qualified route, so the students, mainly the students that we train ourselves, the international route and the apprenticeship route. Is it worth just mentioning something around the numbers of apprenticeships that we've had, the nursing apprentices?
Yes, I mean, the apprenticeship programme is something we're really proud of, and has been received really well, and is really popular. And I think we're beginning to reap the benefits of that now. We're seeing our apprentices come through, fantastic people joining us on the wards who've had that lived experience of being on the wards for 4 years while they've done that programme. So it really is fantastic. Our aspiration, and we've met this, is to take on 100 apprentices per year, and we're constantly looking how we can build on that. And so far we've been very, very lucky in that we've had that level of interest, and we want to see that continue. But again, we know that it's absolutely predicated on the support people get on the wards, and that they have a good experience. And so far we're hearing some really great things about how well people are being supported. So yeah, we talk about a third when we talk about our routes in, and that has been skewed this year. We've had far more international recruitment, which we are incredibly grateful for, and it's been an amazing response from our international community to come and work here. And then our UK base, we have taken 104. And it's not to differentiate in skill, it's just how we look at how we market and how we draw people in. So it's our UK base is people relocating and newly qualified people, because obviously ideally we want everybody who's trained with us to have a fantastic experience and stay with us.
Great,
Thanks.
Oh, sorry.
Sorry, I just to add to that as well. So we're looking to replicate the success of the apprenticeship programme in midwifery as well. So we're currently working with Health Education England to look at how we can implement the midwifery apprenticeship here in the trust, as well as the maternity support worker apprenticeship as well. So, and we're very keen to launch that in the new financial year. Also, we are working with NHS INE to recruit midwives internationally as well.
Which is a very new route for us, isn't it? We haven't done that before as a country. I think this is the first time, so that's great to hear. And in relation to paediatrics, I was talking to the Dean of ARU today, and they're running a second cohort of paediatric nursing student intakes in January of this year, because they've had such a good level of interest in the programme. So that's good news for us. I know that's going to take us a while to get there, to get the other end as nurses come out qualified, but that is good, positive news for us. So, Ansley, you mentioned that we're doing everything that we can to try and keep people in the organisation, but of course we are also losing nurses and midwives and healthcare support workers. And one of the other questions that comes up frequently is, one of the observations is that we are losing lots of nurses, particularly nurses and midwives, and that the turnover appears to be higher than it has been before. Would you be able to just take us through the turnover thing?
Yes, of course. So across the organisation, we're sitting at just over 12%, 12.1% for turnover. In nursing and midwifery, it's higher than that. It's at 13.6%. But the key here is we've seen a 5% increase in the last year of people at nursing and midwifery turnover. Now, that's a bit of an artificial inflation, because we saw a very low turnover in 2020 when we were in the surge period of COVID. So we are seeing sort of the sort of people now moving on, but 5% increase is high, and 13.6% is higher than we'd want it. We see turnover, and we aim to have it at around 9 to 10%, so it's higher than we want it. And we have been looking at some of the reasons why people are going. We've got people retiring. We've got a lot of people who are going on for career progression, promotion, and sort of wanting the next step, really. And I know, Lisa, you've been doing some work in critical care on looking at the turnover and really digging into that, haven't you? There's an example.
Yeah, so we've been looking at why and asking why on exit interviews where the staff are going. So a lot of our staff have gone to London. They're quite young, and the lights of London are quite attractive at that age, and other opportunities and other training opportunities. So we've had a look at what we offer, and we certainly advocate MSc pathways for our staff once they've completed the critical care course, and this is something we've pushed and will aim to push more, and other avenues as well, such as ACCP roles, clinical academic roles, and just creating those opportunities for people to develop in not necessarily management route. Yeah.
So lots happening within your area and within other areas as well. And Ansley, there's a whole retention work plan, isn't there?
There is. We've got a work plan and we've got a programme group who are really focusing on this and looking across the workforce commitments that we have within the organisation about how that links to retention. So that's about well-being. It's about people's ambition. It's about having the right number of staff, because we know that when we're well staffed, people can enjoy their job and do the job that they're employed to do. So that helps us with retention as well. We're looking at inclusion. We want to be an organisation that everybody feels that they've got opportunities and are treated well. And we're also looking at the relationships, how we behave towards each other, and how we support one another. So those 5 pillars are really, really important. And against those, we've got a number of streams of work that are active in trying to support people to have a good experience and a career here.
Yeah. Brilliant, thank you. You mentioned about, I think, people having a good experience working here. And again, one of the common themes that comes up when I'm out talking to staff across the organisation is we don't like being moved. You know, this is a big problem for our staff, and we are absolutely aware that we on a daily basis are asking staff, either on an ad hoc, a shift by shift case, or as in your area, Lisa, we're actually asking people probably to be redeployed for longer periods of time, in order to ensure patient safety across the whole organisation. Amanda, would you just touch on how those decisions around redeploying staff are made, and also we are committed to reduce those numbers as we bring more staff in, but I think it would just be helpful to understand how those decisions are made.
Yeah, no, thanks, Lorraine. So I guess first of all, before I touch on that, I just wanted to thank everybody, each and every one of you actually, who has been moved, because I know how difficult that is. It's challenging moving to a new area and away from your team. So thank you for that. We do appreciate how challenging it is. So ad hoc movements on a day-to-day basis, we decide that through site safety. So it's site safety meetings that happen 3 times a day. We're looking at the staffing across the whole of the organisation, and trying to make the organisation as safe as we possibly can, with the safest staffing possible across all areas. And unfortunately, at times, that does mean that we are having to move individuals from one ward to another to balance the risk across the organisation. I think it's important to note that we have the operational pool in place now, which is where individuals book onto those shifts, either an early, late or a night, both healthcare support workers, RNs and midwives, with the knowledge that they know that they will go anywhere in the organisation that requires their support. So that's one way that we've tried to reduce the number of moves of our substantive staff, but we recognise that currently we are still moving staff. On average, we're redeploying 50% of staff on a day across the organisation. We're redeploying an average of 730 hours a day. 50% of those are operational, people that are booked onto the operational bank. But that still gives us quite a large proportion of staff that we're moving from their usual workplace. And when we look at our rosters across the whole of the organisation, that comes to about 7.5% of our daily nursing team, so still a significant number. We are committed to reducing it. As I've said, we've got a number of initiatives that are already in place to reduce the moves, such as the operational pool, recruitment, obviously, internal transfer programme and bank enhancements. But we would welcome your feedback on any other actions that you think we need to take to be able to reduce that. And I think that it's important to note that the movements are not just based on our vacancies. It also is impacted by our unavailability. So short-term sickness, our isolation numbers are creeping back up again at the moment. So it very much is an ad hoc picture one point in time at a day, on a day.
And as you say, Amanda, certainly for critical care, Lisa, we recognise that some people that we've redeployed into different areas and places like critical care, which can be very scary for people that have never worked there before. It adds additional pressure to people. So what we've tried to do this time is put out for expressions of interest for people that want to move to critical care, that want that experience, that would be interested in that. And we have had 16 individuals respond to a request for, would you like an internal transfer into critical care, for example, or other areas, but I'm just talking around the expression of interest we put out for your area, Lisa. And we're working through those now, aren't we? Because that would give you the team of people that want to be working in that area, rather than being moved on an ad hoc shift by shift basis, and allow you to give them opportunity to support them and develop them into practice.
Yeah, absolutely. So we were blown away by the response, actually. Thank you very much. So yes, and when you come to work with us, you'll obviously get the wraparound service of the PD team with that foundation programme, the step competencies that we've talked about, and supporting the nurse on the floor. It's a great opportunity, but thank you for coming to support us. We're really grateful.
Thank you. And a massive thank you also to me for everyone that's moved, because as Amanda said, you know, we do appreciate it. We do really understand it really isn't easy moving from your ward area and from your team going into an area that you don't know. But I know that the areas that you go to are incredibly grateful that you do go in and help support. So just while we're touching on moving staff and the numbers of staff that we have on a shift by shift basis, one of the other questions that come up frequently is around, are we using bank enough? Are we are we using bank staff enough? Are there more bank staff? Are we putting the shifts out? And also, are we using, or have we considered using, agency? That was one of the questions that was asked of me a couple of weeks ago. And yes, we are, but perhaps, Ansley, shall I hand that over to you around the bank fill and a use of agency?
Yes, of course, thank you. I think first and foremost is to acknowledge the fantastic work our bank workers are doing, and these are people who pick up bank additionally to their other work, but also people who are registered with the bank solely. We've asked, and they really have responded and are doing a lot of shifts. We have seen a really large increase in the number of bank requests. It's almost doubled during the COVID period, and that's understandable. It's because of isolation, short-term sickness, and vacancies. So we have seen enormous pressure on the number of shifts required. And we're filling, in I call it normal times. Pre-COVID, we would be filling well over 75%. We are now filling around 64%, sometimes 61%, going down into the high 50s. The bank staff, or bank workers, are still picking up shifts. It's because we've got so many, but we are filling about 2/3 of the requests coming in. So thank you. There's some amazing work going on out there. In terms of agency, we were in a very fortunate position pre-COVID that we didn't have agency. We were very proud of that position, because we like to work with our own staff and bank. We are now recruiting agency. We're bringing agency in, and we've had 34.5 full-time equivalent agency workers with us, which again we are really grateful for. We have nothing against the individual who's working agency. They're amazing and really helping us to provide good patient care. We're out to agency all the time, but there is a national shortage of nurses, which we're experiencing, and midwives, and the agencies are experiencing that as well. So we're always out for agency, looking for people to come and join us, and we are very grateful for the fact that so many have done.
And we use an agency in areas that we've never really, I know we've not used agency really across the whole organisation, as you say, Ansley, but certainly in areas that would never have necessarily have considered it before. So for example, midwifery have a number of agency lines now, don't they, and a number of regular agency workers.
They do, yeah.
And critical care is the same, isn't it, Lisa?
Yeah, we've got 4 regular agency nurses now who are highly skilled. They've integrated really well into the team. Obviously, as Annesley's alluded to, quite a contentious issue initially, but once you're myth busting with your team, and actually they're working alongside and the patients are getting the right care, it's what's best for us actually and for the patients. And they've integrated really well. They're highly skilled professionals. Yeah.
And I think something that I think critical care and midwifery have done, and I know we've done in other areas such as theatres, we've asked colleagues, what do you want us to do? Yeah. Do you want us to bring agency in, or do you want us to put additional shifts out? How do you want to do it? The feedback is, if you can get agency, bring it in. So we're trying to respond to that.
Yeah. Great, thank you, and great to hear that they're integrating into the team, Lisa. And yeah, I've heard some really good positive feedback. Just while we're talking about bank, one of the other questions that's frequently asked is understanding how bank enhancements are agreed. So Amanda, I know you're part of that process. Will you just give us an overview of how bank enhancements are decided?
Yeah, of course. So we have a weekly bank enhancement panel meeting, whereby all of the divisions who require bank enhancements apply to that panel to have enhancements considered. What I would encourage you to do is, if you're concerned in your areas with regards to your staffing and you feel that bank enhancements would support you, please discuss with your divisional head of nursing who can support you with the application process. It's a very small form. I'm making it sound much bigger process than it needs to be. Within that form, you just need to include your vacancy rate, your expected turnover, and any unexpected short-term sickness or unavailability. So if you've got high isolation, that will obviously require you to need short-term support. Those applications are reviewed on that weekly panel meeting, and then the CUH portal has a list of areas that enhancements have been applied to. So it's a really quick and easy process, although I've probably made it sound much more complicated than it needed to. There's different rates of escalation for bank enhancements, starting at level 1 up to level 3. We do have an extraordinary level in place at the moment on our nights op pool for RNs, which is 100%, but that is not the norm. And we're probably the only organisation in the region that are offering those sorts of rates, because we've recognised that staffing at night, particularly for our registered nurses and midwives, is challenging.
Yeah, and those rates, just to be clear, for the night shift, Amanda, we have I think it's still 10 lines out at night, and for nurses, registered nurses, and 5 for midwifery. Yeah. And that's 100%, but the expectation of those shifts and the people that take those shifts is that they will be asked to work and expected to work anywhere that they're required across the whole organisation. So hence there's a push further on the shifts, the enhancements. Is that correct?
That's right, yeah.
Okay, thank you. So hopefully that's helpful, and people can just look on the portal to try and understand where the existing enhancements are. And they're only put on for a period of time and reviewed then through that same group, aren't they?
Yeah, they are. So usually they're around about 4 weeks sort of time period. We have seen longer periods because we're obviously looking at what our pipeline is and what our turnover rates are in certain areas. But yeah, they're reviewed regularly, and the portal's updated on a weekly basis. So Tony helps us with that. So thank you, Tony.
Great, thank you. So one other thing I just did want to touch on is what are we doing around wellbeing? And again, this comes up frequently across the organisation, and some people do have access to psychological support or are aware of some of the wellbeing initiatives that are happening across the organisation. So Annesley, I don't know if you could just touch for us on this. There's a huge amount of work that's happening on wellbeing. And then Lisa, I'd really appreciate if you could just talk to us about the new role that you've just qualified in, which is the professional nurse advocate role, and how you see that might impact, particularly for nurses across the organisation. But Annesley, should we start with the overview first?
Absolutely, thank you. And you're right, there's absolutely loads going on, and the key to that is signposting, so that people know exactly what's available and where they can get help if they need it. And people don't need to be in crisis to need some wellbeing support, and that can be very practical support, or it can be, you know, other sources of support as well. So we've got a range of things in place. We've got the vaccination programs, which means that we've got early access and easy access on site to both flu, COVID boosters. We've got the psychological support that's available through occupational health and other outlets. We've got specific programs working in some areas as well. And we've also got practical support. We know that people have struggled with debt. We know that people struggle with childcare, and we can give practical advice as well. And people can make contact with third-party organisations. So there is a lot going on. There is also the support we provide to one another, and we've been working on that through the leadership circles, which brings groups together to explore how they can support one another, how line managers can work with their teams to make sure that they feel supported. And we've also got the Line Managers Hub, which gives practical ideas about how to enhance your skills as a line manager, and that feeds into that well-being. It's how you provide support, you provide help, and you provide assurance to teams. So lots and lots going on, and I would urge anyone to sort of go on Connect, have a look around, or reach out and ask your line managers, ask centrally in workforce, occupational health, and nursing teams what might be available. But please don't be afraid to ask. We're seeing sickness absence going up. We know that people are really struggling at the moment, and we want to get the help to everybody.
Yeah. And there's also the chaplaincy as well, isn't there, Ansley, who are doing lots of work, I know, and going around to visit teams as well. So massive thank you to them as well, because I know they're making a significant difference.
Yeah, sorry, I should mention as well, the trade union, our trade union partners have a lot in place. So, you know, if people are a member of a trade union or want to reach out to trade unions, please, you know, details are on Connect, and they're also a fantastic source of support.
Thank you. Thanks, Ansley. So the key message is please do reach out, because there is support there, and we can help direct. You know, use your sisters, charge nurses, matrons, heads of nursing. Come to any one of us directly. Lisa, just finally before we finish, just really keen that people hear about the new role that you've qualified into, the professional nurse advocate.
Yeah, absolutely. So I was really lucky to be on one of the first modules that happened earlier this year and was endorsed by Reese May, the chief nurse. So it's a professional nurse advocate role. And the training is a level 7 accredited module, which is out of quite a few universities across the UK. And I think there's over 1,000 nurses now that have gone through the module and are now branching out to try and endorse the role within their trusts. So the professional advocate role came on the back of the PMA role. So it was a professional midwifery advocate, and that was developed in 2017. And they used the AEQIP, Advocating for Education and Quality Improvement model to support their midwives through difficult times and to improve resilience within midwifery workforce. So that's what we're going to aim to do with the P&A role, and it's about restorative clinical supervision. It's not counselling, we're not therapists by any means, but what we can do is provide a safe circle for people to reflect and to talk, and it could be about anything. So it could be about a project that you're working on, it can be about communication issues, it can be about pandemic and what you've just been through. What we've done in critical care is we've introduced this within our team forums. So the HCAs have had a reflective circle time, our NAPs have had a reflective circle time. We're focusing on our new starters and our student nurses currently, because they're quite a vulnerable group coming into critical care in the way that we're working currently. And then, or it could be that you're doing a piece of research and you need some support with that research. And again, it's about signposting, and it's a safe space, and it's working really well. There's quite a few P&As in training across the trust, and we're trying to bring all those together. I'm meeting with a few over the next couple of weeks to talk about how they facilitate sessions, and that we've got a support network as well, so we can support each other. It's a really exciting role, and so it's got many arms. And so the one arm is restorative supervision, and then the other arm will be about the education and quality improvement. You've all got some brilliant ideas. You want to drive nursing and practice forward, and again these circles are about helping and supporting you through that and helping you support service change, as well as the restorative side, which is really important currently with what we've all just been through. Yeah, so it's great.
And you're a massive advocate for that role, Lisa. You can feel the passion
really
coming from you, which is brilliant, isn't it? So yeah, it's great to hear, and it's great that you're managing to embed some of that into some of the ways that you're working in critical care. So
yeah, and I think it's important because we don't know that we need it. Like Annesley said, sometimes we don't know that we need that support. So we were a bit sneaky. We introduced it into some study days and gave them a 40-minute reflective circle. They had the option to leave. They didn't have to stay. And actually, the people in that session, and we've done it subsequently in our other study days, they didn't know they needed it, was the feedback that we got, and it was very well evaluated.
Brilliant.
Yeah.
And you're right, we have got a number, haven't we, Amanda, of people in training now in the P&A roles, and we're putting more people onto cohorts as they come up.
Yeah, so we're working with NHS-INE to access that training. We're looking for some more volunteers who would like to undertake the training in January and February. Probably about 4 per cohort at the moment, but we're up to about 25 now in the organisation. So it's great. What we just need to work out in the background is how we can publicise the role in the trust, how we can ensure that there's a quality of access for people to access those restorative supervision sessions. So we're working on that governance piece at the moment.
Right. Thanks, Amanda. So talking about communicating with the trust, and I'm very conscious that we're running over time now. Apologies, Tony. We are working on an infographic. So as I said at the beginning of the session, we've tried various different methods to get information and out to the organisation, particularly around numbers of people, nurses and midwives coming in, numbers of leavers, sickness levels, etc. Just sharing that so that you can share that with your team. And Tony has kindly been working with us on an infographic. We have a bit of a draft example, Tony, that we could put up on screen, I think, if we can share. This will not be the final version that we will necessarily send out, but again, really welcome feedback from you all. Just something very visual where you can see our current rates, you can see the number of hours that are redeployed, so you can explain to your teams that this is happening across the organisation, because sometimes it can feel quite personal to teams, explaining the sickness rate, etc. And as I say, this will change over time, but our commitment is that we will get this information out to you in an easy to read format. So thank you, Tony. So just as I say, conscious of time, Tony, are there any immediate questions on Facebook that we need to respond to?
No, nothing coming through, but we will keep an eye out. If obviously people will watch this back after, if questions do come up, we'll make sure that we respond to them as they come up.
Thank you. And this is a different way of trying to get information out to you. We'd really value feedback on whether this has been helpful. We're keen to do further sessions, and we may focus those sessions in on, for example, we may do a focus session on just on maternity, or we may decide to do a focus session on retention. We're really open to suggestions from you all, so please do let us know what would be helpful for us to cover in future updates. And finally, just a thank you to everybody here on the panel. So thank you, Tony, for your help in arranging this, and Lisa, Amanda and Ansley for answering the questions also brilliantly. And finally, just a massive thank you to all of you out there, everything that you are doing to keep our patients safe, all the hard work. We do really understand how challenging it is currently, and I hope that this session has been helpful to share with you the work that's going on in the background. So thank you, everybody. Thank you. Bye.
Thank you. Bye-bye.